Welcome to episode 2 in series 4 of Diabetes Health Matters. My name is Dr. Joan St. John. This series is sponsored by Eli Lilly and Company and Menarini, although they have no input into the content of this webinar series. I'm delighted to be joined again by Dr. Joan Claude-Katte, who is a clinical diabetes researcher working in the University of Exeter and also at the National Obesity Centre in Yaoundé University in Cameroon. In the previous episode of this series, we talked about type 1 diabetes, or should I say, you thought you knew about type 1 diabetes. Well, actually, there's a lot to find out, a lot of new things, because Dr. Katte has been doing some groundbreaking research in the field of type 1 diabetes and its presentation in the global community. In this episode, we're going to talk about type 2 diabetes. And again, you may think, I know about type 2 diabetes, but actually there's lots of different types within that umbrella term of type 2 diabetes. It might be ketosis prone. What does that mean? It might be young people developing type 2 diabetes. It might be monogenic or one type of gene type of type 2 diabetes. There's so much for us to still learn and so much that we still don't know. So stay active in the chat, ask lots and lots of questions. We'll have our Q&A, but we'll also try and answer some of your queries and questions in the chat. So do stay active, and I'm going to now welcome Dr. Joan Claude-Katte. So welcome, Dr. Joan Claude. You're going to tell us what we don't know about type 2 diabetes, or what we thought we knew, which might be different.
Thank you very much for having me again on this episode of Diabetes Health Matters. And yes, we're going to be talking about what we know, what we thought we knew, and what we don't know about type 2 diabetes.
And also how that may be different from type 1 diabetes, and how we could determine whether somebody is living with type 1 or type 2 diabetes, because we know quite often there's a misdiagnosis or a misunderstanding that can occur. Can that occur?
Yes, that can occur. Remember, we talked about that the lines between type 1 and type 2 can be blurry. For example, if you're a young person and you from black heritage, for example, and you live in the UK and you go to the hospital and you're sick and you've got diabetes, if your BMI is low, naturally, the doctor might think that you've got type 1 diabetes, but you may have lean type 2 diabetes. And so what we see, occurring always is that young people who are non-white may develop type 2 diabetes, but they are labeled as having type 1 diabetes either because they're presented with ketosis or because they are lean. But generally, it is known that about 40% of young people are misdiagnosed as having type 1 diabetes, well, meanwhile, they've got type 2 diabetes.
Thank you so much. So we're also going to be talking about what we call ketosis prone diabetes, which can sometimes be mistaken, misdiagnosed, misunderstood as type 1 diabetes. So yeah, another type 2 diabetes that people may not be fully aware of. If you want to refresh your memory, learn more about type 1 diabetes, please go to the YouTube channel and see the previous episode where, again, we should have said, do you think you know all about type 1 diabetes? Well, we're going to tell you some different things. So definitely stay tuned, stay active in the chat. All the questions that you've got to ask us, please put them in the chat, and we'll have a Q&A as well afterwards. Dr. Jean-Claude, what are the sort of standard understanding of type 2 diabetes before we go into uncover and unpick the many different types?
Usually when people talk about diabetes, that's the general term diabetes, they generally allude type 2 diabetes. And why is that? Because it's the most predominant form of the disease. So, I mean, if we look at the recent estimations from the International Diabetes Federation Atlas, we are looking at an estimation of about 600 million people in the world currently having or living with type 2 diabetes. That's quite huge.
So, Dr. Jean-Claude, I'm going to unpick some things there again already. So, as you said, when people are talking about diabetes, people may be talking about type 2 diabetes. I know that people living with diabetes like to specify what type it is. So people don't like that general term diabetes. So this is just to say and to acknowledge that we have to be specific about what type as much as we can, because as we said in the previous episode, sometimes it's difficult to be absolutely very clear and precise about what type of diabetes somebody may be living with. It accounts for somewhere between 90 to 95% of all people living with diabetes. Is that true to say?
Yes, that's true to say. It's the commonest form of the disease, and as you rightly said, so if you're looking at 90 to 95% of the disease, so you're still looking at close to about 540 or 550 million people living with the disease worldwide. And I don't know, as you can see from this slide, which was the estimation from 2021, all the different continents of the world are affected with with diabetes, and precisely type 2 diabetes. And it is estimated that regions of the world that would see the greatest increase of the disease obviously would be sub-Saharan Africa, North African region, the Middle East region, where the numbers are growing exponentially. And as I said, it's actually growing rapidly in some of these settings where it was thought previously that type 2 diabetes had lower numbers. So I'm sure each and every one of us have at least a family member or no family members who have, or even do live with type 2 diabetes at some point. Traditionally, there are two key aspects in the origin of type 2 diabetes. I mean, we were taught this in medical school, and that's what many people still hold. And the first pathway is that the body develops insulin resistance. And what does this mean? It means that the pancreas secretes insulin, but insulin does not act normally in by way of bringing down the blood sugar. And so we say the body has developed insulin resistance. But also, it's important to note that in type 2 diabetes, the pancreas already starts developing some form of insufficiency in insulin production. So there is also that aspect. So those are the two traditional ways through which we develop type 2 diabetes. But now we know that there are several other mechanisms by which we can end up having a high blood sugar in our body, either due to some dysfunction in the way we absorb food from our intestines, either through disruption in the way the kidney, I would say, clean up glucose from the urine production process, either through the way the brain coordinates the activity. The brain coordinates everything that has to do with digestion, that has to do with elimination from the kidneys. But also it can be as a result of the fact that we have, due to some mechanisms, we have our fat cells, fatty tissue is being converted rapidly back to glucose in our blood, or also the liver just producing excessive amounts of sugar that was initially stored. So what am I saying? In the nutshell, there are several different mechanisms through which someone can develop diabetes, or in this particular case, type 2 diabetes.
And you've outlined what the difference there is, the sort of fundamental differences between type 1 and type 2 diabetes in terms of the autoimmune condition of type 1 diabetes and type 2 diabetes, what we call multifactorial, so many different factors coming together. That's the basic science. We've said that it's global. We've said that it's different from type 1 diabetes. That's our sort of standard understanding of type 2 diabetes. Some quick fire questions, and then we're going to look at the different types, if I can call it that, of type 2 diabetes, or the different expressions, maybe we should say, of type 2 diabetes. So, quick fire questions, the associations of type 2 diabetes. I think most of us could say some of them. I'm going to say being overweight or obese. What other quickfire associations could you give us?
There are two main branches of risk factors. You have risk factors that we call non-modifiable. For example, your age. You cannot reduce your age. And we know that for diabetes, one of the greatest risk factors is your age. I mean, not only diabetes, but for many other diseases, whether Alzheimer's, many chronic diseases. If we were to grow as old as the world is going to allow, we would probably all develop all these chronic diseases because of the wearing down of our cells and the tissues of our body. So age is the number one non-modifiable factor. But also ethnicity. It seems that being a black person, for example, or other non-white groups carries a higher risk for developing type 2 diabetes. And you cannot change this, That's why we say non-modifiable. So that's 3. The next one I would say is having a history of someone having type 2 diabetes in your family, which ties to your genetics, for example. Now, concerning the things we can modify, which we call the modifiable risk factors, you mentioned, for example, being overweight or being obese, smoking, excessive consumption of alcohol, we know increases the risk for type 2 diabetes. Living in a very stressful environment and probably association with depression can increase the risk for type 2 diabetes. What are some of the other things? I mean,
lack of activity.
I was going to come to that. Lack of activity, physical activity. It's associated with that. Carries that risk of developing type 2 diabetes.
Thank you so much. So I want us to go on now and talk about different types within the umbrella of type 2 diabetes. And I think one of the types I'd like us to talk about first of all is ketosis prone type 2 diabetes, because as far as I understand it, this is something that we of African Caribbean heritage are more susceptible to, and the presentation of this, I want us to talk about that, because for me as a clinician, quite often I have encountered people who may have this type of type 2 diabetes who have been mislabeled or misdiagnosed. So I really would like us to spend a few minutes talking about that. So tell us what we mean when we say ketosis prone type 2 diabetes.
Yes, this is a very interesting, I would say, subtype of diabetes, because I've been looking at this recently, just looking at the data. So this was first described early on, in parts of the Caribbean, in also parts of Africa, parts of Africans living in the US, where clinicians found out that they are individuals who develop diabetes with ketones which, contrary to what was taught back in those days, was that we would only have ketones in type 1 diabetes. And so it was said that there are some individuals who tend to present with both features of type 1 and type 2 diabetes. They also noticed that these individuals were not overtly overweight or even obese, as one would naturally see or traditionally see in people who develop type 2 diabetes. And so when they started studying in depth this form of diabetes, a typical form of diabetes, they found out that it was common in non-whites, as you rightly mentioned, people of African ancestry who were middle age. And remember, middle age is something difficult to determine nowadays, but usually around the ages of 30 and 40. And they were insulin deficient at the time where they were diagnosed with the disease, and to the point where clinicians had to administer insulin. So they were insulin requiring at the onset of the disease. They would usually have a strong family history of diabetes. They were mostly males, and as I said, they were not overly obese. But one of the most important things in the definition of this type of diabetes, ketosis prone, is the fact that after that initial episode of ketosis, they would usually go off insulin and may probably stay off insulin or even off their oral medications for a period of time. So there's some sort of a reversal of the ketosis, and they would stay without insulin for a long period of time.
And as a primary care clinician, what I detected was that quite often people who had ketosis-prone diabetes, type 2 diabetes I would call it, were labelled as having type 1 diabetes and were left on insulin, and then were having things like hypoglycemia, so low blood glucose, because they didn't require the insulin after that sort of acute period, whatever it was that causes that onslaught to sort of tip people over into the ketosis production. And then when things have settled down with insulin treatment, they no longer needed the insulin. So you have to be aware of it, I think, as a clinician, that sometimes people are ketosis prone and it's an onslaught like an infection or something like that will tip the person over into ketone production. They require treatment with insulin and other treatments, but then after a while they may then go back onto orals, or as you say, even sometimes not require any oral treatment.
As you described beautifully, when people go off insulin, in some of our studies also that my mentors have done in Cameroon and others among Africans in Paris, in France, have shown that individuals with ketosis-prone diabetes can have a mixture of ketotic decompensation or non-ketotic decompensation over time. And there are factors, as you rightly mentioned, that can precipitate this decompensation periods, either infections at onset, and we've also studied in within the African setting how this presentation ties with the onset of rains, like the rainy season. And so when the dry season is setting and the rainy season is coming, we see lots of individuals having this ketotic decompensation that can be tied with maybe viral infections in the environment as well. Other studies have been done trying to look at what are the factors that may make Africans develop this subtype at onset, looking at specific genetic mutations such as G6PD, mutations, sickle cell mutations. It's not really been fruitful whether these genetic mutations contribute to this onset of ketosis in type 2 diabetes. What I would also say is that one very important study that was published, I think back in 2008, showed that certain viruses, and they actually displayed this in vitro, so really strong, showed that certain viruses can, and in this case, they studied and showed that herpes, the human herpes virus 8, which is also the virus that causes Kaposi sarcoma, the blood vessel or blood tissue cancer, precipitates certain individuals in to develop ketosis-prone diabetes. So there's a lot here, but I think that there's still a huge amount of work that has to be done, even within the area of ketosis-prone diabetes, to see why they present the way they do, but also what is the natural history of the disease and whether it's different from individuals who develop type 2 diabetes but without the ketosis. And I'm going to end here by saying that when we've now looked at the genetics of these individuals who present with ketosis-prone diabetes, it looks exactly like individuals who have type 2 diabetes. So it is fair to say that it is a subtype.
So I want to take you forward now to talk about another type of type 2 diabetes. So again, in this umbrella, I had mentioned one of the associated factors with type 2 diabetes is being overweight or obese. However, here we go again, complicating matters. There are some people who are, can I call them lean? So not overweight, not living with overweight or obesity, who develop type 2 diabetes. Can you tell us a little bit about that? Because I think that will be quite a surprise to some people.
One of my colleagues, Dr. Davis Kiberije from Uganda, showed beautifully also, I think 2 years ago, that in Uganda, about 30% of individuals develop diabetes from onset and they are lean. They are not obese. So this is now data coming from Africa, and I've got some colleagues who have gone back to look at some of our data from Cameroon, and they are actually showing the same thing, that there is 30% is a huge proportion of people developing lean type 2 diabetes. And that traditionally, if we stick to the traditional focus of, for you to have type 2 diabetes, you have to be overweight and obese, then it means we are going to miss about 30 to 40% of Africans, especially, who develop type 2 diabetes.
Type 2 diabetes. And, sorry, go on. I was going to ask you, Dr. Katte, could it be that they are phenotypically, so when you look at them, they look lean, but if you were to do something like a DEXA scan and look at their pancreas and look at their liver, that they still have fat deposition within the pancreas or the liver?
That is a brilliant question, because, of course, as we know that when we talk about lean, we are using a very crude measure here, which is the BMI, the body mass index. And we know with regards to how people develop chronic diseases, now there are different BMI thresholds. For example, in Asian populations, they don't use the same thresholds that, we use in Caucasian and African populations. And so when we say lean, it is usually at that BMI, less than 25. Now, when studies have been done, for example, in people of Asian ethnicity who develop diabetes lean, based on BMI, studies in the past showed that, yes, on a BMI standpoint, they are lean, but when the DEXA scan have been used or other sophisticated imaging techniques, MRI, magnetic resonance imaging, or the scan, they found out that individuals in Asia had higher deposits of fats in the organs, in the abdomen, and in and around the abdominal organs. So BMI, which is a crude measure, might not be the best measure of, I would say, insulin resistance in this case, but the measure of these visceral abdominal fatty tissues can be a good measure there.
So I want to move you on to another subtype, if we can call it that, under the umbrella of type 2 diabetes. Maybe not a subtype, it's just a shift in our understanding, a shift in the prevalence, a shift in the incidence. Type 2 diabetes occurring in young people. And again, depends what perspective, but we're now saying young as being less than 40. That is the usual definition in this context of young. Do you want to say a few words about that?
Yeah, so in this context of young, what people call young onset type 2 diabetes, for example, others will call it early onset or juvenile onset type 2 diabetes. Studies would usually draw a line around between the ages of 30 and 40. So some studies, say 35, but most studies would use 40. Yes, if you're young, remember what we said in the previous episode, it was generally thought that, you've got type 1 diabetes. But now we are seeing lots of young people developing type 2 diabetes. Why? Because the levels of obesity generally or globally is also increasing. So obesity seems to be the most important factor driving the young onset of type 2 diabetes. And so if you take a population of young people who develop type 2 diabetes, you would see that over 80 to 90% of them are obese. So that's what we know about the global presentation. So for you to develop type 2 diabetes, I will say this over, at a very young age, it means that you have to be highly obese because it's mostly driven by obesity, and then the other factors of genetics, family history, and your genetics. So, but now, given that I study, mostly African populations or native African populations, we recently looked back into some of our cohorts in Africa, and I did this work specifically with Dr. Kiberigi in Uganda as well, who set up a cohort called the Ugandan Diabetes Phenotype Study, so the UDIP study. And so we looked in his cohort, young people developing type 2 diabetes below the age of 40, and looked at their characteristics and compared their characteristics to a standard European population. And we used the StatRight study, which is a prospective study of all types of diabetes in the UK, for example. And what we found after doing this analysis was that in the UK, for you to develop type 2 diabetes, there was a higher proportion of female, like what we already know, and they had all the increased markers of fatty deposition. So high BMI, high waist circumference, which can give us a clinical measure of abdominal fats, and they had lower markers of insulin deficiency in the UK white participants in the StatRight study. But within the UDIP study in Uganda, we found out that sex did not matter. So sex didn't play a role in whether these young people develop early onset type 2 diabetes. Waist circumference as a measure of abdominal fat did not matter in Africa. The most important factor was whether they were producing enough insulin or not. And so what are we saying? We're saying that for an African, for example, to develop young onset type 2 diabetes, BMI may not be the driving factor, but the most important factor maybe whether your pancreas is functioning well enough already.
Amazing. So I think we're going to tie it up there because it's brought up so many questions. As you say, should the treatment be the same? How do you discern whether that is the type 2 diabetes that a young person might be living with is driven by them living with obesity or being overweight, or is it some other factor that would be the predominant feature for them? You know, the multifactorial nature of type 2 diabetes, the misdiagnosis that can occur with ketosis prone type 2 diabetes. There's so many questions, so I'm going to ask people to ask those in our Q&A and ask them in the chat, and we'll leave it there because there's so much for us to unpick. And thank you so much, Dr. Katte, for sharing your knowledge and highlighting these different aspects which come under that umbrella term type 2 diabetes.
Thank you very much. It's always been a pleasure having these conversations with you. I think this is very important, especially for our community, for the Black community in the UK, picking up these differences so that clinicians can be aware, and also that, you know, our general community can be aware that there are some differences that exist between the way type 2 diabetes presents in a white Caucasian population, and, you know, and the population from which we come from. We should be aware of these differences, and we should know, once we are aware, then we can start thinking about ways we can treat type 2 diabetes in a more targeted fashion within our Black community.
Thank you so much. Thank you.
Thank you.
Thank you, Joan, and thank you, Jean-Claude, for this introduction. I'm going to turn on my camera. My name is Adeyileka-Tracz, and I work with Diabetes Africa. Welcome, everyone, to this event. Thank you for joining us this evening. I want to jump into the Q&A. We've received a lot of questions, and I guess to begin with, perhaps, Jean-Claude, you could help us summarize a little bit what we've just discussed, because we've discussed a lot of things and there are some words we haven't heard and people have asked about this. So we've looked at the early onset type 2 diabetes. We've talked about the lean type 2 diabetes. We've talked about ketosis prone diabetes. What about MODY, the maturity onset diabetes of the young, is that, if I'm correct? Where does this fit?
I think we are going to be talking about maturity onset diabetes of the young in subsequent episodes as well. But this is, remember at the start of these, Joan talked about monogenic forms of diabetes, which, you know, diabetes caused by a single defect on a gene, so a single mutation on a gene. So, and when that diabetes manifests somehow around adolescence or early or middle age, it's usually referred to as monogenic diabetes of the young, so MODY diabetes. When it manifests really early on around infancy, usually less than 6 months of age, then it is called neonatal diabetes. So, but we will be dealing with that in subsequent episodes.
You're right to point this out. We've already had 2 weeks ago an episode solely on type 1. So if you haven't seen it, have a look at our YouTube channel. And in 2 weeks' time, we'll be talking about type 3, type 4, type 5. There's so much to unpack on these topics. So today we will try and focus our discussions on type 2 and the various ways in which it can manifest itself. I'm going to go back to the questions in a moment. I would like to turn your attention to the fact that we've got polls and quizzes. And if you are on your mobile, you may have to swipe right or left to find the poll function. If you are on your desktop, it should appear in your screen. We'd like to know a bit more about you. If you can take a moment to answer the question about your background and whether you identify as Black, African, Caribbean, or Black British heritage. That would be very helpful for us to understand and tailor our content. Whilst people are voting, I will turn to another question that we've received, and that was from Clive. Very simply, how can you know which type of diabetes you have, of type 2 diabetes you have, and why does it matter in terms of care?
Shall I
That is
go
an
first with? Oh,
yes,
shall I go
please,
first with that
please.
one?
Yeah, go
So,
go.
yes, and Clive, thanks very much for asking the question because I think it is an important question to answer as best we can. So, I think the first step is to distinguish what type of diabetes a person may be living with. So, is it type 1 or is it type 2? That's, I think, the first important thing to distinguish. And when you distinguish and diagnose somebody as living with type 2 diabetes, whether we would say that that person is living with ketosis prone type 2 diabetes or early onset type 2 diabetes is I would call it the expression of that condition in that individual. So the ketosis prone would express itself in terms of the production of ketones, the person becoming quite unwell if they experience something like a severe infection or a period of dehydration might tip them over into what we call ketosis prone. And that is a condition that then requires insulin treatment, which may be additional to the treatment that the person is on currently. Early onset type 2 diabetes is in a way more easy to determine because the definition as it currently stands is somebody who develops type 2 diabetes. So you have to make that distinction between type 1 and type 2. Having made that distinction that it's type 2, if they're having that before the age of 40, then they're classified as being early onset type 2 diabetes. So there's no specific test to say what subtype or expression of type 2 diabetes. It's about the diagnosis between type 1, type 2, and then perhaps the age range that that person is in. Jean-Claude?
Yes, I'm going to add something about the clinical relevance of making a distinction between type 1 and type 2, and even some of the subtypes of type 2. Now, if you're type 1, your treatment is insulin, for example. We talked about this in the first episode. There is no oral therapy for that. You need insulin replacement therapy. So, and imagine you've got type 1 diabetes and then you're misdiagnosed as having type 2. It would mean you'll be put on oral tablets, possibly, and you would probably not be well controlled on tablets. That means you're going to live with high blood glucose, and therefore, which is going to expose you to complications early on. So, and then on the other hand, imagine you've got type 2 diabetes, but you're diagnosed as having type 1 diabetes. It means you're going to be put on insulin continuously. The cost is higher. Maybe if you're in the UK, you have access to easy insulin, but if you're in Africa, insulin comes with a huge cost. It comes with all the hurdle of continuous measurement. So, and then, carbohydrate counting, if you want to go deeper into, into dieting and how to measure. And so that person who should have been on oral tablets and well controlled would be overlaid with all the other things that come with having a diagnosis of type 1 diabetes. So it's important to have the diagnosis right because it has, I would say, what's the word in English? Sorry,
Consequences.
consequences, like immediate consequences on the individual, but of course, the immediate family of the individual. So I just wanted to add that therapeutic angle to it.
Absolutely.
So we've got a question, but I will add some information around it. The question was, how can you reverse type 2 diabetes? I want to point out that we have, with Joan and with other excellent speakers, covered type 2 diabetes reversal in detail in previous episodes. So please have a look at our YouTube channel, search reversal type 2 diabetes, and you will find a wealth of information and some of our most popular videos. However, I want to color a little bit this question for this episode and ask you, Jean-Claude, all the various types that we have mentioned, are they all, can we all reverse them potentially?
You're on mute.
Yeah, I was on mute. Some 10 years ago, the current and direct answer will be no. Type 2 diabetes is, you cannot reverse it. But now we know, coming from evidences from studies, led beautifully by researchers in Newcastle, for example, with low-calorie diet, have shown that you can actually reverse type 2 diabetes. But also, those studies have shown that there are people who respond so well to this low-calorie diet and they reverse their diabetes. There are others who don't respond so well and they don't reverse diabetes. So you have to be aware of those, of, the differences that can happen. And currently, there are many studies being carried out to try and make the difference. Who are really the true individuals that should be put on this line of therapy, knowing that they would reverse their diabetes or not? That is important. So I'm sure Joan will want to add to that.
Yeah, just to add another small addition, in that one of the key things, my understanding is the duration of living with type 2 diabetes makes it more amenable, seems to make it more amenable to
Absolutely.
potential remission or reversal. So, in answer to the question in the chat, it's not the age at which you're diagnosed, but how long you've been living with it. So, I think this is in some ways a positive message that the more you can do to get your blood glucose levels or as keep your blood glucose levels as close to normal for as long as normal, there is something called a legacy effect. And that legacy effect means that the closer you can keep those blood glucose levels to normal, the reduction of risk for you in the future. And as I say, there is this window of opportunity, it would appear, that when somebody's diagnosed as living with this condition, that is your opportunity, or that seems to be the maximum time in which you can achieve remission or reversal.
Thank you very much, Dr. Joan. And lots of information is also available in the World Foods book that you have published. So I want to highlight that if you are looking for advice on how to handle food, specifically if you're looking at food of African and Caribbean foods, this book, World Foods book by Dr. Joan St. John and other co-authors is available. And we also have episodes of Diabetes Health Matters specifically on food. So do have a look at our content. And the next question, and the polls are continue to run. So please do take part. And I'm very happy to see that a vast majority of people are learning this evening. So keep the questions coming, and we will make sure that everyone this evening goes home or goes to bed with something new that they can share with friends and colleagues tomorrow, something that potentially you can also change if you are a healthcare professional in your practice on Monday. A question came up about the microbiome and type 2 diabetes. What do we know much about the influence of microbiome on type 2 diabetes? If we're to cover the causes and the ways that this can influence the condition, Jean-Claude, what can you say about that?
Yes, I would say that this is an interesting and growing field, the relationship between the microbiome. The microbiome is actually a term for just all the microorganisms that, live in our gut. And when I say microorganisms, I mean, bacteria, I mean, viruses, parasites, and fungi. So all these microorganisms that live in our digestive tract. And the evidence with regards to how diabetes relates with the microbiome is still really growing, although it is known that the types of, I would say, population of these microorganisms you have can influence the way your body secretes certain substances that can push you to become insulin resistant and then would carry you over the line to have diabetes. So, but there is actually very strong evidence from mouse models to show that if you change the microbiome of a mouse, that mouse can easily develop diabetes and some can easily develop obesity. But in human research, there's still a lot of work to be done. So yes, the microbiome can influence the way someone would develop insulin resistance. And of course, insulin resistance is very closely related to obesity and then diabetes. So that's what I'm going to say for now, and just really add that it's an area of growing interest and growing research.
Thank you, Jean-Claude. Joan, did you want to add something?
No, just to say that I think it's a fascinating area of research. It has been going on for a little while now, and I think if it was possible to show that there was a definitive link, then it is going to offer us another therapeutic pathway. So the more therapeutic pathways we can have, the better, I feel. But yeah, that's the only thing I can add.
Thank you, Joan, and thank you, Jean-Claude. Another question was about the role of GLP-1s in the treatment of diabetes. The question was very vague, but we hear a lot about GLP-1s. And do you want to give some background information about this buzzword?
Yeah, it's really a buzz treatment nowadays, right? And I would just say simply, yes, it's an anti-diabetic medication. It was actually first developed for GLP-1s, were actually first developed for diabetes before being used for every other, for most of what we know around obesity and also for cardiovascular diseases and such. Yeah, so it is a treatment for diabetes. Yes, it is used for diabetes.
And of course, all treatments must be discussed with your healthcare teams. Joan, do you want to insist on this point?
Yes, absolutely. Because we are so aware and so recognize that every person is an individual, you have to have that discussion as an individual with your healthcare provider to know what is the best treatment for you. But what Dr. Jean-Claude said was absolutely correct. Initially, this class of medication was produced to relieve high blood glucose levels.
Thank you very much. I am going through the chat to make sure that we have covered all the questions. Please don't hesitate. If there's something that you really want to ask our experts this evening, put it in the chat or ask to one of the ask the question to one of our team members who are on the chat currently. The next question I wanted to ask you was about type 2 diabetes. Type 2 diabetes, there are some people who are living with type 2 diabetes who also have sickle cell disease. The question was about the fact that HbA1c readings can be void. Can you clarify exactly, because many people who are of Black African Caribbean heritage will have sickle cell trait. So how does this impact the diagnosis, I guess, and even possibly also the treatment, Jean-Claude?
Yeah, that's a really important question, especially if you're of Black heritage. Like myself, for example, I live with a trait for sickle cell, and we know that if you've got sickle cell, the severe form of the disease, which is the SS, so obviously your red blood cells will not live as long as someone who's got the normal AA or even AS. And so unglycated hemoglobin is strongly related to the aging of your red blood cells, or how long they live, so which is usually around 3 months. So if your red blood cells live shorter because of sickle cell, because of G6PD deficiency, because of thalassemia, these are all blood diseases that are very common in people of African descent. If then you would tend to have lower levels of glycated hemoglobin. And um, I think it's really still an ongoing area, and it is advised that glycated hemoglobin in this particular instance may not be best for diagnosis. But if you have already been diagnosed with diabetes, we could still do glycated hemoglobin to be able to measure your level of control when you're on treatment for diabetes. Now, whether that matters depending on the type of glycated hemoglobin test that is done, whether it's HPLC method, which is high performance liquid chromatography, the standard method, or is immunoassay boron affinity using point of care instruments. Um, we've shown with studies in Uganda with my other colleagues that it may really not matter which method is used, and whether you have sickle cell trait that can be used confidently to measure your blood glucose and treat you adequately.
Thank you very much for this. Joan, did you want to add anything?
Yes. So in the UK, the other thing to add is that quite often results are reported giving an indication that there may be what we call a hemoglobinopathy, as Dr. Jean-Claude-Katte had described. So whether that's sickle cell condition, or whether that's thalassemia, or whether that's glucose 6-phosphate dehydrogenase deficiency. But the reporting will also clarify to say it does have an impact on the glycated hemoglobin, or it doesn't have an impact on the glycated hemoglobin. So in the UK, it is reported quite commonly like that. So if it doesn't have an impact on the HbA1c, the glycated hemoglobin, you can accept that glycated hemoglobin, that HbA1c, as being a true reading. If it does have an impact, then they would normally advise that you perhaps do something like the fructosamine, which is a slightly different measure of how much glucose has been within your blood system, if I can call it that, for the previous 2 weeks, as opposed to the previous 2 to 3 months. So that's another way that you can have a look at how the glucose levels are. In the past, what we used to do, if somebody was living with a hemoglobinopathy and it did affect things like the HbA1c, we would sometimes do, if we're talking about diagnosis, a glucose tolerance test. Very rarely is that done these days, I find, but that is another way to ascertain whether or not somebody might be having diabetes or living with diabetes in the context of also living with a hemoglobinopathy.
Thank you very much, Joan. We'll take a couple more questions, and then we'll bring the event to a close. Thank you so much for your participation, everyone in the room. I want to acknowledge Roslyn and Gugi, who's with the Kenyan Diabetes Study Group, and she's asked a very topical question in relation to what we discussed with the GLP-1 treatment. For people diagnosed with lean type 2 diabetes, does it mean that the the option of the GLP-1 agonist should be avoided in favor of DPP-4 inhibitors, because GLP-1s can lead to weight loss. Is that the right interpretation here? I'm not. I hope I'm not changing Rosalind's question too much.
I think that's the question, and it's a very important question. It goes without saying that traditional conception and ideation would say don't use GLP-1, right? Because you're going to cause the person to lose more weight. But I'll just stop there first of all and say that we haven't done any clinical trials to see which would be the best drugs in this case. It may interest you to know that we are currently in the final phases of doing a clinical trial to answer what would be the best drug for lean type 2 diabetes, especially in Africans. We'll be doing these studies in Cameroon and in Uganda. Unfortunately, we haven't included GLP-1 in the medications that we would be randomizing, obviously, for financial reasons, for cost. But we have all the other drugs that are common, metformin, sulfonylureas, and DPP-4 inhibitors that would be included for randomization in this clinical trial. So watch that space, and we want to try and demonstrate it, scientifically, that this would be the best drug for lean type 2 diabetes.
Thank you. Joan, any further comment on this?
No, I'm going to watch that space, and Dr. Jean-Claude will have to come back.
Yes. Thank you. I just want there were some questions in the chat that were very specific to individuals about a medication. We're not able to answer these questions in the Q&A, unfortunately. So we really encourage you, if you've got very specific questions, it is something to discuss with your healthcare team. However, in the question, I picked up a topic that was also raised by someone else, which was, I'm going to paraphrase a little bit, but what can we do better for people living with diabetes who are of Black African Caribbean heritage, particularly in the UK, or what can we do better? What advice would you give to healthcare professionals? Because the figures, the statistics on outcomes are not as good as for their white counterparts. So I wanted to start with you, Dr. Joan, perhaps, because you've been really looking at this question of equity in care, and I'll let Jean-Claude think about it in the meantime. But Joan, what can we do better for people of Black heritage living with diabetes?
So we've had 2 all-day conferences on addressing inequities in people living with diabetes. I think there's a huge amount that can be done. We can start with communication between healthcare professionals, healthcare providers, health service systems, and the communities living with the condition. A culturally tailored, a culturally specific, culturally relevant approach. We can talk about education, which will involve things like awareness of the condition, and again, with a culturally tailored, culturally specific, culturally relevant lens. I mean, there's so many things. We could have a whole episode plus on it. But I think the important thing is to listen to the community, see what they, as individuals, as a community, as a group, want and require, and try and tailor the service that you have towards that, because there's that cliche, one size does not fit all.
Yes.
Jean-Claude?
Yes, I'm going to look at it from the other angle, and I'm going to pull the cover to my side as a researcher. Most of the evidence that we produced for therapy, and especially through clinical trials, And when we look at the people who participate in these clinical trials, obviously it comes back to issues of access and all the like, but we tend to see they're mostly, white Europeans. And so we are actually creating a world where we are making drugs and testing these drugs or medications in a population, in one population, and generalizing the treatment to all other populations, including Africans. And what I want to say is that we also need to engage with our communities so that we can participate more in producing the evidence that would be tailored for us. We can go into the way different drugs work. There are many anti-diabetic drugs, many antihypertensive drugs that work differently in white people than in Black people. And that might be the reasons why, your maybe blood sugar is not well controlled, or your blood pressure is not well controlled. But we cannot know all these things if we don't bring, our community to participate actively in research, to participate actively in creating policies so that our voices are heard in the global agenda for change for diabetes. So I think I'm going to end there. If not, I'm going to go on and on. So.
Thank you so much, Jean-Claude, and that really gives us something to work on in the future. I see a lot of people saying thank you because we're coming to the end of the episode. There is still a poll that is open at the moment, and we are asking you if you've enjoyed this episode, if you would kindly rate it. So if you haven't answered, please do so. Thank you so much, Dr. Claude-Katte, Dr. Joan St. John, for this very interesting and interactive session. Thank you everyone in the room for participating. As I mentioned, the next episode will cover type 3, 4, 5, and I think we'll stop there for now. We'll have many other topics, so please do subscribe to our YouTube channel, and also go online to subscribe to our newsletter if you would like to stay informed of our activities. If you are in the UK, on the 26th of November, we are holding a UK forum for healthcare professionals. So if you want to meet with Dr. Claude-Katte and Dr. Joan St. John face-to-face, please come and join us on the 26th of November. The details are on our website, www.diabetesafrica.org. I'm going to pass on the mic to Jean-Claude and Dr. Joan for final closing words for this.
I think final words for me would be type 2 diabetes is really quite an interesting disease, quite varied. And so if you're a person living with type 2 diabetes, you should know that you're unique, and that the way you should be treated should be unique and specific to the way the diabetes manifests or presents itself, as Dr. Joan said in the beginning. And really interesting conversations, and I'm so really happy to attend and to partake this particular episode, and to briefly answer those questions. I'm sure we're going to meet on the 20th for many of you, and I'm looking forward to being there.
And I would just say thank you to Mr. Diabetes Africa for moderating the questions again. And thank you so much to Dr. Claude-Katte, I apologize, for another wonderful session, another wonderful episode with lots and lots of really useful, interesting, and groundbreaking information. So, yes, thank you all for participating. Thanks for the really interesting questions. I hope that we have provided answers to those tonight. But remember, check out the YouTube channel because there's hours of information on there as well. So we look forward to seeing you in 2 weeks' time, because some people asked about MODY, some people asked about type 5 diabetes. As Mr. Diabetes Africa said, type 3, 4, 5 and MODY will be dealt with on the next episode. Dr. Claude-Katte, You've been amazing. We really, really appreciate you sharing your expertise with us. And everybody have a really good evening and hopefully see you in 2 weeks' time to learn more together. Thank you.
Thank you.